my name is Michael Ivan. I'm one of the neurosurgeons here at University of Miami that focuses on brain tumors and skull base. Today I'll be talking to you about one of our connectomic cases. So this is a 50-year-old gentleman who presented with some very mild speech difficulties and had an MRI here that shows this heterogeneously enhancing lesion in the inferior temporal lobe. So if we look at the MRI scan here, we could see it's very well circumscribed. It's posterior in the temporal lobe, involving most likely the middle temporal gyrus here back towards the vein of Lobe. And so you may be saying, okay, well, you know, this is a good spot because it's below Wernicke's, it's below the superior temporal gyrus, but we would still do the case awake and map just to be sure. So we loaded this into Quicktome in order to understand where the tractography and the parcellations would be, to understand really where those areas of language and speech would be, and what is the best way to map this patient to be most safe. So let's load up the tracks and parcellations. So here what I've done is just focused on the language system. We've located the left side parcellations and also the tractography. Focused on the language system and also the accessory language, since that's what we're most concerned about in this area. As we scroll through the axial, you can see here, up top, we're seeing areas where Broca would be. We could follow it down to the temporal lobe, going down this way. And this area is most likely where Wernicke's is going to be. And we can kind of look in the coronal as well to kind of understand these areas of these connections. What's interesting is, although these fibers are coming up superior to the lesion in the superior temporal gyrus, which is where we expect Wernicke's to be, we could see there are some parcellations and also some small twigs that are going very close to our lesion, especially right here. And so the questions are, really what's going on here? Are these twigs important? And how do we ensure safety? And that's really where Quicktome kind of comes in to help. So for me, what I'm trying to understand is really what part of the language system is this, and are we, when we plan our surgery to do the awake mapping, is this test and the awake monitoring that we're going to be performing capture what the deficit potentially is in this location? So when we look at the individual parcellations that are going through here, we would focus on the temporal part of the language network. And we could see that there's 5 components here. And basically do process of elimination, we can kind of understand, okay, what one of these parcellations will disappear when we unclick it using Quicktome. So if we identify here, this is the parahippocampal temporal parcellation. And when we unclick this, we can see that it immediately disappears from in the tumor in the network that's most surrounding the tumor. And so, and when we look at some of the other ones, STS, let me try to get a better picture here for you. Yeah. So the STS, which would be the superior temporal sulcus parcellations, VP and DP, those are a little bit further away, a little bit more anterior. TE1 is inferior to the lesion. And so what we're really worried about is the temporal network. And so if we look up on, what is this network really involved in language, and what is its role in language, and how important is it, that will help us kind of guide us towards what are the specific tests in the surgery that we need to make sure we check off. So we know when we do Wernicke's, we do naming, and we talk about repetition, and there's certain tasks associated with those. But the parahippocampus gyrus is mostly involved in kind of the controlled retrieval of conceptual knowledge. And so it's really this weakly association between objects in space. And so sometimes naming may not be enough to really elicit this deficit while you're stimulating. And you may need to do something like picture association or a more complex awake mapping monitoring procedure in order to understand. And so these are the kind of things that Quicktome could really help pull out. We know that a patient, we can't do 3 hours of monitoring for this patient to understand this, but we do know that if we kind of hone in on the 1 or 2 specific tests, we can get a really good awake monitoring evaluation during surgery. Now granted, this tumor comes to the surface, and so we can core it out very easily, but the question still remains of how aggressive can you be in this area, how well beyond the margin can you go, and what should you be looking for as you go beyond the contrast enhancement. And so that's what we did. So here I could show you what the preoperative MRI and postoperative MRI looks like with a T1 contrast. And you can again see the lesion in the posterior middle temporal gyrus, inferior temporal gyrus, and then again show that we did a small corticectomy. We were able to stimulate language superiorly, normal naming, and then we did additional advanced language mapping throughout the resection cavity, which was also positive, and therefore really limited a supramaximal resection of this lesion as expected based on the preoperative Quicktome. So not only did it kind of tell us that our resection had to be very focused and focal, but also really honed in what skills we need to understand on how to map this patient during surgery for the safest outcome. Thank you so much for this case, and I'm looking forward to sharing more with you.